We have till 1:30.
Okay.
If people need to leave before then, that's okay too.
Okay.
Hi, folks. Welcome. We're going to start in a couple of minutes. We'll just give people time to join us. Okay, let's get started. I see more and more people joining us as we get going, but I think we have lots to talk about today, and I'm really excited to be here with you all and like to use our time. I think there'll be, lots of good discussion to be had. So for those of you who do not know me, my name is Rebecca Penn. I am the project manager for the National Safer Supply Community of Practice. To get us started, I would like us to start in a good way and begin with a land acknowledgement. So we come together in this community of practice from across Turtle Island as people who live on treaty lands and ceded and unceded territories. We're all treaty people. In the spirit of truth, reconciliation, and respect, I'd like to acknowledge the land where I live, Sogum-Keegum, colonially known as Shelburne, Nova Scotia, which is part of the traditional and ongoing territories of the Mi'kmaq. We work in a sector whose goal is to address social and structural harms. We recognize that the production of these harms comes from our colonial history and its enduring practices, institutions, and ways of thinking in our ongoing daily lives. We know that Indigenous people, as well as members of African, Caribbean, and Black communities, are disproportionately affected and harmed and criminalized by drug policies that are rooted in racism and colonialism. Colonialism is with us today, and we commit to working in ways that transform racist and colonial institutions and practices to repair harms, prevent future harms, and work towards a more inclusive and equitable future. I ask that each of you take a moment to reflect on how your work is connected to the work of decolonization and social justice. If you would like to put in the chat, if you'd like to introduce yourselves and let us know where you're calling in or joining us from, that would be great. So a little bit of housekeeping. We are recording this event and we'll share it on our website. We have English closed captioning enabled, and we're going to have the setup for today is some presentations, some brief presentations, and then we'll follow up with a discussion, and there'll be a poll in between that I'd really appreciate if you would complete for me. You'll have some questions that you might want to pose to our panelists and get discussion going, and that's great. Please use the question and answer box if there's anything you want us to bring up at the discussion time. If you put them in the chat, they'll get lost. So if you put them in the Q&A box, that lets us keep track of points that people want to bring to our attention and discuss after the presentations.
Rebecca, it says chat is disabled. Or sorry, the Q&A is disabled. Or sorry, chat is disabled. A few people said that message saying chat is disabled.
I'm so sorry. I'm not sure if I can even deal with that while we're all going, but let me see what I can do. Okay, let me just go through this quickly, and then I will look at that while our panelists are introducing themselves, if that's okay. Okay, so for those of you who don't know about the community practice, the project manager has technical difficulties. That's the first thing to know. What I really want you to learn about us is that we are an organization of almost 1,900 people from across Canada. It's an interdisciplinary community consisting of pharmacists, physicians, people who use drugs, researchers, nurses, people working in policy, all kinds of people who care about people who use drugs, their quality of life, and their access to evidence-based care. So our goal is really to focus on how to improve access to a continuum of substance use healthcare options. To work towards that goal, we provide some clinical consultation opportunities, support for programs. We do knowledge sharing and knowledge co-construction through working groups, and we offer webinars like this. We do have a certificate for people who are joining us today who would like a certificate. About halfway through the webinar, we'll pop a link in, and you can click on that link and get a certificate. And again, just if you want to join the community practice, Tanya's put a link in the chat there with our website and how to join. So you can have a look at that. I'm going to go look at the web to see if I can change the settings for the chat, and ask Tanya if you could introduce yourself, and then Michelle, Andrew, and Lucas, and then I'll come back and just do a little introduction to our discussion, if that's okay.
Perfect. Thanks, Rebecca. Welcome, everyone. My name is Tanya. I am a peer navigator here at CMHA Guelph, Ontario, also a co-founder of Reclaim Collective, person with living experience, and good to be here. And I'll pass it along to Michelle.
Hi, everyone. I'm Michelle Olding. I'm joining here from the traditional unceded territories of the Anishinaabe Algonquin, but I am based at University of Toronto, where I'm a postdoc, and I'm part of a broader great team that looks broadly at access to harm reduction and healthcare for people who use drugs. And I'm pleased to be here today presenting on our team's research. Lucas, do you want to take over?
Sure. So I'm Lucas Martignetti. I'm a PhD student at Ontario Tech University, but more relevant to the work here. I'm a research coordinator with the Center on Drug Policy Evaluation with St. Michael's and Unity Health in Toronto, part of the team working on the evaluation of safer supply programs. And Andrew, you can go next.
Hey everyone, I'm Andrew, a physician with CATC, and I work at all spectrums of opiate use disorder, but I'm part of a 4-site pilot project we've been doing with Safer Supply over the last year, and I'm happy to talk about, and thank you for being here.
Thanks all. It doesn't seem to be working. What I'm thinking I'll do is start a Google Doc that we can all just plop questions in. So I'll put, because you can access what we put in the chat, right? So I think it's really important to me that people are able to participate, and so I feel very frustrated by this chat not working. So let me see if I can figure that out. Yeah. I feel like I can do that while I am, while the others are speaking. So I'm wondering if it's okay if I just do my little intro to our conversation here, our little setting the stage for our presentations. So let me do that. So I just want to acknowledge a couple of things. I want to start by saying why we're here and why safer supply is a thing. We're here because we care about the lives and well-being of people who use drugs, and we care about the harms related to substance use. We care about all members of our communities. We care about the 50,000 deaths in Canada due to the unregulated drug supply and the countless harms that have occurred. Those attending this webinar may or may not be members of the community of practice. As I said, a group of almost 2,000 people who represent diverse roles from across Canada and beyond. There are so many different people who are members of the community of practice working in so many different settings. And with that comes a diversity of opinion about how we provide safer supply. but there is consensus that safer supply is an important tool in the toolbox for substance use healthcare. There is recognition that safer supply is an approach to addressing the harms and deaths caused by the unregulated drug supply, and it is something that people who use drugs have been calling for decades. I'd like to suggest there's also recognition that traditional approaches to care, even the gold standard of OAT, doesn't necessarily work for everyone, and that for many people, interactions with the healthcare system, perhaps especially addictions medicine providers, has been characterized by experiences of stigmatization and violence. When the community of practice was formally established in 2021 to support the implementation of SUAP-funded pilot projects, one of the first working groups that was struck was on diversion. Diversion is an issue that has been front and center from the very start. Along with the collaboration among pilot projects to develop protocols and policies to prevent and address diversion, this working group produced an FAQ about the importance of addressing diversion from a perspective that wasn't rooted in a moralistic understanding of people who use drugs, that didn't assume that people who use drugs lie and manipulate because they're bad people. Instead, the FAQ, which at its essence is an anti-stigma document, suggests that trusting, collaborative relationships between people who use drugs and healthcare providers can be fostered. And this works to keep everyone safe and well. The report looked at research evidence and engaged the lived experiences of members who are people who use drugs and healthcare providers. And the central idea emerged that key to addressing diversion is to address unmet needs for both individuals and the larger community, and also this trusting relationship between healthcare provider and client patient. A principle of harm reduction is the recognition of the tragic harms that substance use can have in people's lives. And as people working from a harm reduction approach, we recognize we need to be attentive to any unintended negative consequences. So diversion's always been on the radar. Just as we were about to launch our report, our Reframing Diversion report in 2022, the topic of diversion in the context of safer supply programs exploded in the media. And we saw safer supply become a highly politicized issue. Since that time, politicization has increased, with people who use drugs and inadequately funded harm reduction programs being used as scapegoats for larger policy and social issues, including poverty, a crisis in the number of unhoused people, inadequate access to healthcare, including treatment and mental health services. Messaging has placed harm reduction in opposition to treatment, an either-or scenario that is not based in reality. We know that they exist on a continuum of substance use healthcare, and we need all the tools to support the health of people who use drugs, no matter where they are on the spectrum of use. Messaging has also relied on dehumanization and stigmatization of people who use drugs, positioning them outside of community and fostering an us versus them mentality. So I'll briefly acknowledge the news from BC yesterday that in BC, they're moving to witnessed-only doses for safer supply clients as a way to reduce diversion. And we'll address this, I'm sure, as we move through our webinar. And but I do want to say, like, how you define problems is how you identify solutions. When we define a problem like diversion as relating to the untrustworthiness of people who use drugs, answers like witness dosing make a lot of sense. But is that the right definition of the problem? Understanding why diversion happens is key to developing strategies to prevent diversion and to respond to diversion that is occurring. Over the past couple of months, 3 new peer-reviewed papers were published that address diversion in the context of safer supply programs. The findings of these studies won't surprise any of us. These published findings validate what we've been hearing from people who use drugs and from care providers for years. And it also validates or reiterates what we've read in the literature about diversion related to other medications. But I'm really excited about this webinar today because it provides us an opportunity to discuss the implications of these findings and think about how we can move forward to ensure that we're providing the most effective approach to care for people who use drugs. And that's why we're all here, right? So one last thing about before I turn you over to our panelists, I want to address who is on the panel today and who isn't and why. We have 3 panelists, 2 researchers and 1 physician. When I approached Michelle and Lucas and asked if they'd present their findings at a research spotlight webinar, we were really excited. We envisioned having a large panel made up of many people, including healthcare and social care providers and people who use drugs. We knew that the findings weren't going to be surprising, as I said, but we thought it would be great to provide an opportunity for people to share their thoughts about the findings and make it a really interactive session together. Ultimately, I decided that although I love this idea, it was a lot to ask of people right now to speak about this topic in this current context. Marlene Haynes is another researcher who co-authored a paper about diversion that just came out last week. One of the things that Marlene talked about, unfortunately, Marlene wasn't able to be here today, but one of the things that is addressed in that paper is the fear that people have about talking about this topic. There are very real consequences for people. And we didn't, we felt that the 4 of us were in a privileged perspective, or in a privileged position in which we could talk about this safely. And so we are missing on this panel the voice of people who use drugs and other service providers and their perspectives. And that's a big gap. I just want to acknowledge that and explain why that is. I'm going to get to the chat thing. I'm going to put together a Google form that will let you put things in, and I'll be able to see I'll be able to see what you write in there right away. And I do welcome you to share your thoughts and experiences in this form or in the Q&A. I just want you to keep in mind that this is a public webinar. We are recording it and we will be putting it on our website. And so I want you to think about what you're saying, how you're saying it, and whether or not you use your name. You can change your name in Zoom, and the Google form won't ask for your name as well. Tanya, can you put in the chat there? There's instructions about how to change your name in Zoom.
Yeah, but they won't be able to see it.
Oh, you can't see either. Okay.
They can't see it either. No, so I can put it in the, well, it wouldn't matter to put it in the doc then.
Okay. All right, let me go do the Google and I'll put it in there. And I'm going to let Michelle and Lucas start with their presentation. And my sincere apologies. I made a mistake with the chat. Thanks, Michelle. Can I turn it to you? Turn it over to you.
And I'll turn it to Lucas.
Oh, okay, good stuff.
I'm going to share this here. Just want to make sure people can see the screen being shared. Thanks. So myself, Lucas Martignetti, and Michelle Olding will be presenting our research on diversion in the context of safer supply. We'll get into our research in the next few slides, what we found. For the agenda very quickly, we're going to be looking at the background of diversion, the methods we use for our 2 studies, our findings, which are broken down into experiences, perspectives on diversion from both clients, participants in safer supply programs, as well as programmatic practices related to diversion, as well as our key takeaways and implications. So for the background, what is diversion? So for the definition chosen, I went with something that I think is broad and I think is very encompassing of the very diverse methods and reasons for diversion. So it's the displacement or unintended use of prescribed safer supply medications. Rebecca covered this in some detail as well, but much public discourse, particularly the last, 2.5 years, surrounding safer supply has centered on diversion to opioid naive individuals, particularly to youth. At this point, there's currently little peer-reviewed evidence regarding how diversion is occurring within these programs. So what we have here is we have two separate independent studies looking at diversion among, again, clients. In Michelle's case, her team's case, looking at prescribers and allied health professionals. But we have two completely independent papers looking at this, independent studies. Michelle and I actually had no idea that we were working on very similar work. We had very similar findings, and we only realized this when we bumped into each other at a conference. But we had our two different studies looking at this published in about the same month. So it just kind of worked out that everything came out at the same time. And we had a lot of, again, overlap in what we found. In terms of our methodology, Michelle's team looked at 4 sites in Toronto and London. My team looked at one community health center in Toronto. Michelle's team looked at, as I said before, clients, participants of the programs, as well as providers. So again, that's prescribers and allied health professionals. My team was only looking at the experiences of program clients. In both cases, we had a brief sociodemographic survey and it followed by in-depth semi-structured qualitative interviews. Our questions were asking people about their perspectives, their experiences, both personally and what they've seen, what they think of diversion in these programs, and for analysis, both thematic analysis of the interviews. So our findings are broken into reasons for diversion in programmatic practices, reasons for diversions I'm going to cover. Programmatic practices, Michelle will, just because her paper went on and did that extra step. For diversion, again, we found very similar things, so I'm going to be presenting for both of us. Those reasons for diversion can be broken down into compassionate sharing, addressing unmet needs, both for medication and survival needs, as well as a demand for safer alternatives, and diversion through displacement, theft, and coercion. So compassionate sharing was the, between both our studies and different studies as well, was the most reported reason for diversion. That is sharing with others, that's friends, partners, people at risk, people experiencing withdrawal who are dope sick or at risk of overdose. So just seeing other people and doing what you can to, address those symptoms and the risk of overdose, and doing what you can to help those around you. Within that, sharing was most commonly reported with opioid using romantic partners. So again, just addressing the needs of people around you, that they have the unique ability to do this through their prescription. Something to note is that we had in my study, especially, there were people who were not yet in the program who received diverted medication because they were experiencing withdrawal, and they were able to join later, but they had that kind of introduction to the program through diverted medication. As well, another reason for diversion is addressing unmet medication needs. So that is people coming in from accessing the unregulated drug market, which has been for years. Fentanyl has been either the most commonly available or the only available opioid. So people are coming in with very high tolerances, and then when they're only given hydromorphone and maybe a slow release medication such as like Cadian, their needs aren't being met in terms of their tolerance. So what people are doing is they're supplementing that, they're trading, potentially selling their medication to get fentanyl. And what's typically the case is that people will be using more fentanyl at the beginning of the time of the program and kind of weaning, tapering down to mostly or entirely using their prescribed medications. As well, survival needs are something that it can be met with diversion. Typically, poverty, being unhoused is a driver of, again, selling or trading medication to meet material needs. Again, same with people's use of the unregulated market of purchasing fentanyl. This is something that we typically see at higher rates as reported here, at higher rates at the beginning of someone's time in the program and decreasing over time as people are better able to meet their needs. A lot of the time, people find more stability in their life once being in the program. They're able to seek regular employment or better able to access income that they're not able to meet. They weren't able to meet before, with the hustle of securing money and securing opioids through unregulated markets. We've seen a few times here, and the middle quote talks about this, about how people would do survival sex work, and that would end after their time in the Safer Supply program. As well, selling unprescribed doses was considered very rare. This was the case in both studies where, again, anyone selling all their medication was not particularly common. As well, the low resale value of Dilaudid, or really any sale price of Dilaudid, was not enough to compensate for experiencing withdrawal. The last sentence of the quote here, I'll save the whole big wealth of $2 and keep my medication and feel proper. So at low value, this was also mentioned at any value, it just wasn't worth selling your Dilaudid because you're still going to be dealing with withdrawal. As well, there's a demand for safer alternatives in the unregulated market. There is a high demand. There's a value for an opioid for a drug with a known composition and potency. As the unregulated market seems to be, increasingly dangerous, volatile, unpredictable, there is a particular value in knowing exactly what you're taking, what's in it, the composition, the potency of it, compared to, potentially taking benzodope or, the different kinds of tranquilizers and things that have entered the unregulated markets. Displacement, theft, coercion are drivers of diversion as well. Clients, when they're known to be in the program, especially with the very low capacity that a lot of programs have, the long time that someone might be spending on a wait list means that there is, there's value to this Dilaudid, so that people may be harassed, coerced, targeted for theft. They may be robbed to get their Dilaudid, again, because there is this, value for it. Because again, these programs are not able to necessarily address everyone who would benefit from them, or just for whatever reason, the format of the program may not work for them in their lives. As well, there's particular vulnerabilities to medication loss from being unhoused. The ability to safely and securely store your medication over time makes it really difficult when you don't have that. Anyone who has been homeless, who has worked with people who are homeless, knows that there's a particular vulnerability at night where if you're sleeping, people have their stuff stolen. People may try to stay up all night or do anything to mitigate that loss, but it's very easy, again, without permanent housing, permanent storage, it's very easy to lose your medication that way. I'll turn it over to Michelle.
Thanks, Lucas. So Lucas has just done a good job of summarizing what our studies together had to say about how diversion is happening as reported by clients and providers. And I'll be shifting now to focus on what our research found, looking at how our programs responding to diversion. What are they doing in practice? And so there's really three kind of pieces to this that our analysis looked at. So how are programs seeking to prevent diversion? What are they doing to monitor it? And how do they respond in instances where diversion is identified? And I just want to flag that, again, this is based off of research that we did looking at 4 safe supply programs in Ontario, and this was in 2021. So just keep that in mind, constantly evolving situation. I'm sure a lot of it follows through with what people are still experiencing, but just want to flag the temporality component of when this research was done. Next slide, please. So the findings really speak to how safer supply programs are using multiple strategies to try and prevent or mitigate diversion. So I want to highlight the 2 things that came up the most often when talking to providers. And so when I'm saying providers, about half of our sample was prescribers and the other half were allied health workers or registered nurses. So the first thing that came up the most was around establishing expectations about diversion at intake. That pretty much every provider we spoke to talked about how conversations around diversion and the expectations and consequences and all that were part of the intake process. And especially at this early point, when the programs were being operated, really trying to emphasize to clients the importance of being honest with them about what was going on, that we know that this is something that can happen, and we'd like to know about it if it's happening so that we can develop strategies to address it. So kind of setting that foundation of this is something that we know happens and that we need to talk about, we also take seriously. Next slide, please. But continuing on in ongoing clinical practice, just continuing to have conversations with clients to proactively identify potential drivers of diversion, not waiting for it to happen, but to actually check in with clients to see what's happening in their life that might be contributing to this. So one of the most common things that came up, and I think has to do with the fact that this was done in 2021 when the programs were even operating at much smaller capacity and a lot of people didn't have access, is many clients had partners that were eligible for the program but weren't enrolled. And so they were sharing their medications with their partner out of concerns for them overdosing or in withdrawal. And so providers talked about talking about this with clients and trying to prioritize enrolling those partners so that they could also benefit from safe supply and they wouldn't be having to give up their medications. Next slide, please. In terms of monitoring diversion, like how do you actually follow whether and how diversion is happening in your practice? I've already spoken to, obviously communication and trust with your clients was foundational in everything. But the other two main things that came up were the use of urine drug screening. So urine drug screening is used as a routine part of practice in safer supply. When you're starting new medications, but also just to confirm the presence of medications. So they talked about diversion being most clearly identified when there's no dilaudid showing up in folks' urine. And that would be the situation where you would have to have a conversation with the client about what's happening and investigate it. But they emphasized that, this is a non-punitive approach. You're not going to be punished for having other medications showing up, other drugs showing up in your pee. It's about whether there's not your prescribed medication showing up. Secondly, they talked about receiving reports in the community, claims about patients who were diverting, and that they took the credible claims seriously and looking into these. And again, emphasizing the importance of following this up with the clinical tools that they have in terms of urine drug screening, but also, again, the conversations with clients to understand what's happening here. Next slide, please. So how did program providers say they responded to diversion when it was identified? A common thread across most of the interviews was the importance of starting with, an open and honest conversation with the client about what's going on. P can't really tell you what's happening in terms of where those medications have gone or why people are not taking them, right? It only tells you that they haven't taken them. And so they emphasize the need to have these conversations with clients to understand what are you getting from the program, what's going on, and trying to come up with a strategy to address their situation. Next slide. So really the responses to diversion depended, unsurprisingly, on the extent and the underlying reasons for diversion. So in the instances that were coming up around clients who are sharing with their partners, already spoke to. Sorry, I lost my audio. I'm not sure how long it went off for.
Just for 10 seconds.
Oh, weird. Okay. I'll just go over. So responses depended on the extent and the underlying reasons for diversion. So in cases where clients were sharing with their partners, trying to enroll the partners so that was not happening. In instances where clients were, losing their medications or, saying that they were being targeted for being robbed, for example, developing safety plans to address that. So transportation options, medication delivery so that clients don't have to go to a pharmacy. providing lock boxes to folks to keep things secure. And instances, where that wasn't working and where there was concerns that diversion was still happening, they talked about temporarily restricting take-home doses or requiring more frequent urine drug screening or appointments until they could get some stability and resolution around what was happening. But they emphasized that this really has to be done on a case-by-case basis, considering, the benefits and harms of introducing more monitoring expectations on clients, right? So, having to go into the pharmacy every day is a big barrier and might disengage. And so weighing that within the benefits of the program. In cases where all of this didn't work, or in the very rarely reported instances where they had evidence that clients were selling all of their medications, which again was very rarely reported in the data. There was instances of clients being discharged from safer supply, so not discharged from their practice, continuing to offer them opportunities to shift to methadone, for example, or just retaining them in primary care, but taking them off the safe supply program. Next slide, please. So I think, what we can say from, the two studies that we've presented here, as well as Marlene's study that came out, I think it's really, really compelling that we were all independently doing this research, not knowing the others were, taking similar approaches and finding similar things. We have data across the three studies that spans from early 2020 when the programs were starting until late 2023. And in program sites across Ontario. And so this gives us a lot of confidence and credibility around these findings, and especially because they resonate so strongly with what has been found in studies of diversion in OAT and pain management and other settings. It's very similar. That diversion encompasses multiple practices. It's not one instance of people selling their medications for financial gain. It includes trading, it includes sharing, it includes losing your medications. It exists along a spectrum. In our research, we're finding that people are reporting compassionate sharing as the most common. And across all these studies, again, that diversion is reflecting unmet individual and community needs. Next slide, please. So, it's hard to present a slide around key implications when this is such a complex, huge issue. So I just want to caveat this by saying that a lot of the underlying kind of drivers of diversion that our research highlights are issues that safer supply programs alone cannot address, and that are created by policy failures, right? The toxic unregulated drug supply and the demand for safer alternatives existed before safer supply, and it's a big driver of what we're seeing around diversion in terms of unmet need. So I'm focusing here on, what this research can say about what programs are doing that seems to be helping in terms of mitigating diversion. So expanding medication options to better match client substance use needs. Especially during that titration period when people have a very high opioid tolerance, having those conversations around what folks really need to meet their needs. And taking a collaborative approach with clients to develop risk mitigation strategies that actually address their individual circumstances and needs. Again, you can't tell from looking at someone's P what to do in terms of what needs need to be met. You need to talk to them. You need to figure out what's going on. And what came across in both of our studies is that clients of Safe Supply really are benefiting from it and want to have medication options that work for them and work with their providers towards that. So they're partners in this. And finally, providing wraparound supports to address the social vulnerabilities around housing and income supports. So to conclude, just want to thank all of the participants and the study team members who were involved with this. And then I want to pass it over to Andrew to provide his reflections.
Thanks, Michelle. Thanks, Lucas. Thanks, Rebecca. So again, I'm Andrew Patterson. I'm a physician with CATC and part of a small group of us who started a foresight pilot project of safer supply just over a year ago. So I plan to do just an introduction, then I'll talk about how our program works and goes ahead to minimize diversion, and then I'll focus on how the research has been helpful. So, we often talk about this toxic drug crisis, but I don't think we always talk enough about the realities of those most impacted, and that are people who are effectively trapped in a system with little to no meaningful support. Safe consumption sites, encampments, outreach services being removed, leaving people with fewer options all the time. And it's in this impossible environment, prescribed hydromorphone was introduced, not as a cure, but as one intervention to help people separate from an increasingly toxic drug supply. And despite clear evidence of benefit in this population, it has faced intense criticism while no real investment has been made in the root causes of the crisis. And this is, essentially what the reality of the research has illuminated. How people survive or don't survive in conditions of extreme vulnerability and deficit. So the findings on diversion aren't just about one substance. They speak to a fundamental issue of survival in a world where every basic necessity is a struggle. And still the compassion that can exist as people help each other within this community. But the dominant addiction medicine narrative at the moment paints a picture where traditional OAT alone can kind of set people on the right path. But the reality, I think, is a lot starker than that. And I also think it's important to address the pressures prescribers face. Many OAT prescribers remember the rigid 2011 methadone CPSO guidelines in Ontario, where college assessors audited your charts looking for mistakes. You kind of had to get it exactly right or risk being in trouble. Then the crackdown on pain medication with audits, disciplinary action, and again, a growing climate of fear around opiate prescribing in general. And then Alberta showed us just how much governments can interfere by eliminating prescribing entirely and forcing punitive restrictions. BC introducing some new things in that area, and Ontario feels like it's moving in the same direction. So prescribers today are navigating not just clinical risks, but political, media, and professional scrutiny that again fuels this culture of fear. So in that backdrop, our team recognized these prescriber pressures, but more importantly, we kind of recognized that traditional OAT wasn't engaging or retaining these exact people at the highest risk of death. We saw the growing evidence supporting SOS and felt a real duty, I think, to explore this option. And in our role of clinicians, I think ignoring a promising intervention that is helping this exact group of people that are dying isn't just negligence, it can be harmful. So before I get back to how the research plays an important role, let me outline kind of what our approach has been to minimizing diversion, which mirrors what Michelle and Lucas have mentioned, and also the programs where the research has come from. So, and it really starts with eligibility. We focus on people at the highest risk, those with severe fentanyl use disorder who have repeatedly tried and failed traditional OAT. Most are unstably housed, using over a gram of fentanyl a day, often with concurrent stimulant use. So these individuals are actively seeking help because they don't want to die. All have lost countless people to overdose. As was discussed, we have direct conversations about the political landscape and the importance of preventing a diversion, not just for the people's safety and public, but for the survival of the program. And these are people who are not looking to profit off Dilaudid. They're wanting an alternative to the unregulated fentanyl supply. All patients in our program are also on a long-acting backbone of OAT therapy like methadone or Cadian. Dilaudid alone is insufficient due to the extreme tolerance levels in this group. And unlike some reports that some people prescribe only hydromorphone, even to stable OAT patients, that's not the practice we follow and is not typical amongst the programs where research is based. We titrate as rapidly as possible to stabilize people to reduce the likelihood that they would divert in an attempt to self-regulate withdrawal, particularly during the early phases of therapy. And We do have multiple monitoring approaches. We do frequent physician assessments, case manager check-ins, surveys to make sure patients are benefiting, reducing their use. We do daily observed dosing of the long-acting OAT and daily dispensed unwitnessed Dilaudid. We hold doses if we hold the unobserved doses if a patient presents intoxicated, so they're clear about the safety each and every time. We do regular urine screens to confirm the presence of hydromorphone. If there's reports of diversion, we follow up on them immediately with the clinician to, address what was happening here. And we do, in some cases, if we can, the pharmacy delivery directly to shelters, homes, apartments to reduce the theft, coercion, and real sale that could happen right at the clinic or pharmacy. As I think is best practice, we have formal guidelines across all the sites and are doing a concurrent REB approved study to track outcomes on the implications of this program. So with that in mind, I can return to the research and kind of explore how it helps us guide us to minimize diversion and benefit the people we're dealing with. So it was identified diversion happening for three main reasons: compassionate sharing with partners or friends to prevent withdrawal or overdose, selling or trading to meet unmet needs of substance use, or loss due to social vulnerability, homelessness, theft, poverty, coercion. And I'd like to add to that, untreated mental health is another factor. Like social isolation and mental illness can make it even harder for someone to navigate their own needs effectively. And within the diversion realm, it was recognized the spectrum, none at all, occasional social loss to habitual selling. And with the reality being habitual selling is rare. Most people take all or most of their medication as intended. So with that knowledge, what have we tried to do similar to other programs? Pharmacy delivery directly to people, reduces theft, coercion, as well as transportation barriers. Often bus passes, things are just difficult for many people. For financial stability, we help clients access ODSP to improve income. For housing supports, that's a super big challenge, but our case managers are always ensuring connection to housing supports, advocating on their behalf as stable housing reduces vulnerability. And as people become more stabilized longer term on the Safe Supply program, they're more eligible for housing as things in their lives become just more conducive to being in a stable house. And we engage close contacts. The client is a partner, a close friend who is, also using, but not in our program. We work to engage that person in care to eliminate the need for compassionate sharing. And for mental health, I think we all, as prescribers, should deal with mental health and prescribe for mental health, which I think most do. But we are fortunate to have access to psychiatrists if needed to provide more comprehensive assessments and more detailed treatment, as required. So now what does happen in instances? So, back to Michelle and Lucas's point about open and honest communications. One of my clients, I'll tell you a story about this. One of my clients is a young man living in the shelter. And we'd built a good relationship, a good trust over time, talking about his life, his family, tattoos he has, which are pretty awesome. He'd been doing really well in the program, stabilizing, reconnecting with family, which he hadn't done in a long time. And that was huge for him. And then we had 2 urine screens, which came back negative for hydromorph, with no missed doses, no reason why they would be negative. So following standard protocol and wanting to, police this, I suspended his D8 prescriptions due to suspected diversion. I told him about it, told him why, and he accepted it without, really saying very much. Then a week or so later, he approached our case manager because he wanted to share the real story. So there'd been a theft at the shelter, and he and another person had been blamed for it. And he was threatened with significant violence and forced to hand over his Dilaudid prescription for a short period of time. The person targeting him knew when he picked up his prescription at the clinic and where, and would target him on the way back. And what happened when I stopped his D8s? He went off program, fentanyl use increased, and he was forced to return to survival sex work, which was something he'd been able to stop and had been desperately trying to leave behind. So when I heard this, like, I felt ashamed about it. He'd been embarrassed to tell me. He thought he had disappointed me. But the truth is, he was just trying to survive, and I'd been punitive about it without listening more deeply. So, because the pressure we feel as SOS prescribers to police diversion is immense. But, this reminded me that real people's lives are at stake. So in moments like this, I knew for me that compassion had to come first. And I told him that and apologized. Restarted therapy and using his kind of experience as a guide, instead of having to come to the clinic where he'd been targeted, we arranged direct pharmacy delivery to the shelter, do appointments there, because his abuser was not welcome. So since making that change, he's had no further issues. And how would we go ahead with the research? If we were truly guided by research, we would do exactly what Michelle and Lucas have outlined. We'd expand treatment options for those whose needs are not met by D8s. We would expand capacity and recognize prohibition and lack of capacity are a large contributing factor to this problem. And we'd actually invest in things like housing, financial stability, and mental health supports to address the actual drivers of the crisis. Because if we want to address the crisis and the topic of diversion meaningfully, I think we need to start by facing the full reality of the people we serve. And I think your work on diversion's been a critical part of that. So I thank you very much for that. And I'll hand it back to, I think, Rebecca, maybe.
Excuse me. Thanks, Michelle, Lucas, and Andrew. Really appreciate hearing your presentations, your thoughts. Excuse me. I'm going to launch our poll and ask you to fill that out for me. It's just 6 questions, helps us with our funders, and make sure that we are doing something useful for you. And also give you a moment to add any questions in the chat.
Becca, it's saying that host and panelists can't vote on mine.
Can't which?
Okay, we can't vote. Okay. Never mind.
That's just for our attendees. Okay, while people are filling out that poll, we can continue. We do have some questions in our question and answer box. If you have a question you'd like to ask or a comment that you'd like to make, please do put it in the question and answer so that I can have a look at it there. Excuse me. Okay, so the first question is, if diversion is very rare, then how did the price of Dilaudid drop from $25 a pill to almost nothing? Anybody have any thoughts about that? It's outside of the
Can I
research.
just make a point of clarification? Our research doesn't say diversion is rare. It says instances of people selling all of their prescribed doses was reported as rare. So, compassionate sharing is a big part of the picture of why Dilaudid is probably more regularly available in the market and helping. Like, my guess would be that's what helped brings it down. I don't do research in that area, so I can't speak any further to it, though. You have more to add?
When this is not based on, oh, sorry, Lucas, go ahead.
Oh, sorry, I didn't hear. I think Michelle, I think you handled that really well. I don't really have much to add. Sure.
That's all good. One thing that someone mentioned to me once, so this is not like research or fact or anything like that. I thought it was an interesting thing that they mentioned to me when we were talking about this exact thing in one of our meetings. And they said that people want a drug of known quantity, quality, and potency. And so the idea of being able to access a pharmaceutical drug, even in the unregulated supply, was very appealing. And so they thought that there just was an increased demand for Dilaudid that then led to people who sell Dilaudid or sell drugs, who supply fentanyl and other drugs, meeting that demand. How that got into the supply is way beyond what we can, that we don't have that information. There's no facts that give us that information. But I think, you know, it's an interesting thing to think about. Michelle, you mentioned that it can increase barriers when patients have to pick up their safe supply at pharmacy every day. How often are they going to pharmacies to get their meds? If not every day, I thought it was daily dispensed. And this is how, and then it refers to the GOM study. Yeah, do you want to?
I can only speak to what I have in my data, which is, you know, for if they were moved to a witness model, then you would have to go at least once a day to the pharmacy, right? Multiple times, which would be a huge shift from take-home doses of Dilaudid. But I wonder if Andrew might have a better response as he actually prescribes.
Well, in terms of, so in our model, people do either go to a pharmacy or have the long-acting part observed dose every day. So they do, in general, go to somehow receive the medication, whether they're going to a pharmacy or having it delivered to them. They do observe dose that every day. That's restrictive, but that is how our program works, because we've introduced it in a system, a clinic alongside traditional OAT. So then the Dilaudid, they use the rest of the day. So, because this is more in keeping with how actually people use drugs, or any drug, you know, whether it's alcohol. You don't just walk into the LCBO and chug a 60-pounder. You spread things throughout the day. That's how people use fentanyl multiple times a day. It clears out because it's so lipophilic and you get intense withdrawal. So the long acting, you do get it daily, and the unwitnessed, you have that the rest of the day to take you through comfortably 24 hours as you would like to use it, and particularly issues around what to do about nighttime, you know, because that's a part of the day where I think a lot of prescribers or people just assume everyone goes back to their comfortable home and has a nice sleep. That's a high danger time. So that's often a time of day where people really value that. But there is definitely the daily interaction with the pharmacy in most cases.
Thanks, Andrew. Here's a question for you also, Andrew. Do you know off the top of your head about how many of your clients who are on Safer Supply are Indigenous?
It's a great question, Rebecca. And if I'm thinking specifically of, again, and it might be where we are, so I can think of in the site I'm affiliated with, I can think of one, you know, in the town. And that might be reflective. I don't have statistics for some of the other sites. The percentage would be very low. Again, it's a very southern Ontario demographic, but you know, as per always, I think it's a unmet need, not only in our program, but in healthcare, all elements of care, as a generalization for certain.
Yeah, yeah. I will say that for some of the programs, they have the SUAP funded programs. We're very much focused on trying to make sure that populations that are overrepresented in harms were reflected in their client group that were participating. So it's been good to see some, if you look through our program evaluation reports on our website, they give some of those statistics. And I'm thinking of like Parkdale Queen West, some of the others where, you know, 20% of the clients were Indigenous. Yeah, but it's I like your point, Andrew, about, you know, we need to be thinking about making sure who is being reached by these programs as well, and are these programs addressing the specific needs of different groups of folks. Here's a question. Research question. Okay, I find it interesting. A lot of the press coming out of BC focuses on the persons who access safer supply, rather than what was happening with the pharmacies and their involvement in diversion. Has there been any research with pharmacies in Ontario to better understand that? I'm not aware of anything. Are any of you?
Yeah, as far as I know, I'm not aware of any. Um, there's very little like direct research on diversion at all, but as far as I know, there's none directly on pharmacies, and I'm not exactly sure how that it's definitely interesting, but I'm not sure how that would potentially be set up. I think that might be like a wider kind of like ICAS level, higher level data that I think we'd have access to with a very like qualitative perspective. As far as I know, there's no research.
There are reports that Health Canada has around like inventory control kinds of reports, and I'm pretty sure they're available online. But yeah, looking at Health Canada's controlled drugs and substances, yeah, that we might find something there about like in terms of stats that they have about instances of like loss. I know they have different categories around what happens with inventory control when there's discrepancies around inventory control, including like internal losses, or other issues. Yeah. Okay, next question. How do you, this is a prescribing question, Andrew. How do you insist someone is on OAT concurrently? What do you do for a patient who, for example, says, I really don't want to be on methadone, but if you insist, fine, I'll stay at 40 milligrams, thanks. And then they refuse doses or miss doses. This person says they always would recommend OAT. It doesn't seem impractical how you would force somebody to be on OAT, and questions the ethical aspect of that, the ethics of that.
Well, I guess so. If we think about our eligibility criteria, all people have had to have tried oat multiple times. So some variation of it or another. So this is, something that they've shown multiple attempts to want to make changes, and they've tried it. With that knowledge, we also recognize that with the strength of the current fentanyl supply, we just allotted 8 on its own would rarely be, especially in the kind of marginalized population we're dealing with, would be almost impossible to meet their needs. So, and I recognize we're talking about this specific population. There's many people who are not being represented or heard who would use fentanyl here and there, and would probably very much could benefit from like a compassion club type of thing where we get some kind of amount, but as needed. So we decided as a group that we would make an eligibility criteria that was consistent with the fact that we're also dealing with traditional OAT. So we just made a decision to be eligible. Had to do both. So I'm not sure what the ethical, I don't quite know how to navigate that question, but it was an eligibility criteria, and we wanted to ensure that we do the entirety of medical care rather than just dispensing one thing. And we set up a concurrent research protocol. That was part of the protocol. So that's how we went ahead. And with that in mind, I'm just trying to think. I think in general, everyone wants that. I mean, it's the people who have come to the program value the time away from dope sickness they get from the long-acting backbone. And they're also able to value how they use it allotted throughout the course of the day as they wish. In general, most people are not on low backbones. I think one person maybe is on 400 of Cadian, which is a day 1 start dose of Cadian. But most people just require quite a bit more support than that, up to 200 of methadone plus, 1,200 or 1,600 of Cadian along with Dilaudid, and still sometimes are using, or it takes that amount to feel comfortable and kind of have the balance that they're seeking in their life. So I haven't had anyone just seeking tiny amounts or feeling kind of irritated about it. I haven't asked the other prescribers, but it's not come across my own experience. So I'm not sure if that answers your question.
Thanks, Andrew. I think, one of the challenges again is making sure people do have the right medication options. And I think the research on diversion is another, provides information for us to advocate for a wider range of medication options to be available, different formulations and potencies and such. So in Ontario, like we don't have Fentora or sufentanil and things like that. And so I do hear about people really highly recommending oat as a backbone, given that Dilaudid don't do it for a lot of folks, right? So yeah. Next question. Okay, research. What direction should future research on diversion take? What are your thoughts? What do we need to do?
I mean, my immediate answer is we need to understand more about the experiences of people who are accessing diverted medications, who are buying it. We have a lot of focus on people who are suspected of diverting, and we know very little actually about who's accessing it and why. We do have some research, and I hope you can cite it from, I think, Andrew's or Jeff Bardwell's team that looks at this. But if we're really going to understand why and how diversion is happening, we need to understand the demand piece better. Like, who are the folks that are actually accessing this, and what is it doing for them, and what kind of intervention and policy responses are needed to support, the needs that they have for a safer supply. That would be my number one. Lucas, Andrew, what are you thinking?
I wish I had a more original answer than that, which I think is the biggest missing piece, is just our ability to access the populations of people in programs. It's so much higher than getting talking to recruiting people who are accessing safer supply from outside the program. Like there was a few cases of people accessing diverted safer supply before joining the program. And there is that kind of that bridge, that pathway there, but yeah, we just have so little access to these other groups, and it'd be it's incredibly important to get their perspective too. So all I really have to say is ditto to that.
Same.
You. With a possible federal government change, where do you see the future of safe supply programs, and what impact will diversion play? It's a great question. I'd like to just say a little bit more about that question, if I may. I'm thinking about, I'd like to just contextualize it a little further, even outside of a federal government change. We are seeing programs ending at the end of March, so funded programs. Many of them are ending, and I am curious around, the impact that might have on diversion and on the drug market.
What's your question again, Rebecca? Is this something? Just repeat it for me in case there's something I might want to say.
Basically, just what's the future of safer supply programs and the impact of changes in government program funding ending? What impacts might that have with diversion, related to diversion? How's that?
I mean, I could jump in and say that it seems like the direction right now is that the current policy agenda is not being set by the best available evidence. It's being set by other objectives that might have to do with the elections themselves. We now have this evidence here, and we're in a moment where it seems like it's not being heard, and it's not being taken up in the ways that we would hope it would be. And I think maybe Andrew, you made this point in an email, but I really hope that we get to a moment and we keep working towards the point where the evidence will be heard. But I think, what we're hearing from a lot of people outside of research is just a lot of uncertainty, a lot of precarity, not knowing what's happening. And that's devastating for people who use drugs and for clients and people we love. I can only imagine how difficult it is for folks not knowing day to day what's going to happen with their program, especially when they've stabilized, and having something taken away because of anecdotal claims or concerns about diversion is something we should all be really, really upset about. It's not something we should accept for any area of healthcare. So that's my little soapbox. I don't know if Lucas or Andrew has anything to add to that.
Yeah, I just want to speak about, so as part of my interview, so diversion was a small part of our interviews, but one of the last questions I would ask people is, what kind of changes do they want to see? What do they like or dislike? What kind of, policy changes and everything need to be done from their perspective? And most people were very emphatic about expanding the programs, about getting it into the hands of more people who need it as much as possible, just expanding the capacity, usually because they had a long wait time to get in, where it could have helped them tremendously dealing with withdrawal, with their experiences with overdose. So to see the opposite happen with SUAP funding ending for a lot of these programs, kind of shifting to kind of the more kind of direct prescribing model, I think that's going to with just so many less opportunities for people to access safer supply, I think that's going to lead to a lot more people going back to the unregulated drug supply. So again, it's contrary to some of the best available evidence, and also just contrary to the basic wishes and experiences of the people in the programs. Yeah.
Thank you.
If I think about the kind of narrative and diversion narrative, which is really what is defining the kind of fear of the unknown versus evidence-based, if programs did shut down, which I think is like what would happen was that the question I'm understanding? What would happen to diversion if the programs were shut?
Sure.
Well, I guess I still think there would be. I mean, only 23% of Dilaudid that's sold is actually related to safer supply in general. So there would still, I would speculate that the pharmaceutical, some degree, or pressed Dilaudid would still make it into the marketplace, but the return to unregulated fentanyl as the sole most available thing is the experience of what happens when these things shut down, and evidenced by speaking to some of the prescribers who were involved in Alberta, where since shutting their program, a third of their people on their program have died. Whereas people, as a prescriber, you can see people do very well on it and are clearly using it to make meaningful change, and it is benefiting them. So expansion, to Lucas's point in their research, is important, as well as we've talked about before, particularly with you, Rebecca, just better meeting people's needs with different options, which is something happening with some people in BC that are whether it's direct fentanyl itself, something that's actually a better alternative for the subset that this isn't meeting their needs.
Thank you. Just looking through our questions here. Andrew, are you finding IV routes of administration with unregulated tox supply are becoming less popular amongst your client populations? this person's asking a question about prescribed injectable oat options, how they are underutilized, and why might this be the case? Would they
Listen,
not meet our needs?
I don't have the full, like, I don't have the definitive answer, but I can think of almost none of the patients that I have under care injected fentanyl. So when smoking route is almost the exclusive route of use, people aren't always interested in injecting anything. I think that was more, I mean, so if anything, meeting people's needs with smokable options of some form or another would be a critical step. And I would say the same with Dilaudid. So the question, people kind of sometimes like to redirect back to, the witnessed daily injectable options, the IOT stuff, which is just simply not, people talk about it, but it doesn't happen in Ontario. The rules are too rigid. But people don't inject. And in terms of the Dilaudid I'm prescribing, I think I can think of one person who injects sometimes. People eat them. So just injecting isn't a palatable option for a lot of people as the method they use drugs. And I don't know a lot about how it will work. I know there's some clinicians who do some, I think you can do some degree of witnessed injectable. I don't think it's through a program, but through to help individual cases. And, if things shut, I think any and all options need to be explored. Yeah, I don't have much else to say about the injectable options. It's just simply not a route that many people, in my practice at least, utilize.
I've also heard people talk about liking the flexibility, right, of swallowing them or injecting, and doing one thing differently than the other at different times. Yeah. Okay. It's a question about research. Michelle, I'm going to ask you this one because we've talked about this together. You mentioned that you're concerned that policy is being driven by anecdotal claims about diversion, but isn't the qualitative data presented in this webinar simply anecdotal as well? This person's not a qualitative researcher.
Yeah, no, it's very frustrating doing qualitative research and getting this question over and over again. So why do we do qualitative research? We need all sorts of evidence, first of all, on this to understand what's happening, quantitative and qualitative. The strengths of qualitative is that you're systematically asking a group of people the same kind of question to understand how and why something's happening. So that's what we did in this project. That's how it's different from an anecdote. We have a sample of safer supply clients and providers who have the experience and expertise to actually speak to the issue. And we ask them questions in a way that they're all asked the same way, and we analyze the data to make generalizations based off of a larger sample size that is more reflective of the client base. So when I'm talking about anecdotes, I'm talking about, if you're sitting outside of a pharmacy watching to see someone do a drug transaction, that's an anecdote. You're not systematically collecting that across all sites where opioids are prescribed. So if you're making a claim based off of that about how diversion is happening, that's an anecdote. That's not been systematically collected, and it's not been done in a way that can actually answer or speak to the claim you're making. So qualitative research is really about designing studies in a way that you are asking the right questions, you're asking it to the right people, and you're doing it in a systematic way so that the evidence that you produce actually is somewhat generalizable and not an artifact of, focusing on one pharmacy or one bottle of pills. So that's what I mean when I say anecdotes, and I think that's the difference with the approach that we're taking here. And I think also we have tried to be careful here to not overstate our claims, right? So, we're making claims about what we can learn from qualitative research. There's other evidence that's needed, and we acknowledge that. I think when we're seeing a lot of claims circulating, just be very critical about what is this based off of? What evidence is actually being provided? And are folks overstating what they can say with their data? yeah, that's my response to that, I suppose.
Thanks,
Lucas, do you have
Michelle.
anything to add?
Yeah, Lucas, another qualitative researcher, gone through lots of rigorous training to do quality work. Any other comments to?
Yeah, I
Um,
mean,
my-
oh, sorry.
no, you go ahead, Lucas. Go ahead.
Yeah, I mean, I think Michelle nailed it in terms of, yeah, and also, I mean, I think she said at the beginning too, just like it is part of, you know, different data sets working together, qualitative and quantitative. It's not, you know, the be all end all of every experience, everything that's ever happened with diversion, but we can talk, you know, more authoritatively with, you know, about the people we spoke to, and, you know, qualitative research, you know, the value of being able to kind of dig more deeply. They talk about, they use the word richness a lot. If you ever get into qualitative research, they talk about depth and richness. And that's kind of what we provide, is the ability to kind of dig into these questions and have a better idea of also, you know, this can guide quantitative research that will come along too, is learning, you know, what is happening out there and, you know, how better to analyze that. So yeah, it's again, it's part of a broader whole, and it does serve its own, you know, specific place.
Thanks, Lucas. You know, and I think back to what I said at the beginning, is like how you define a problem is how you identify solutions. And again, if we focus on, if we take, you know, stigmatizing stereotypes about people who use drugs as being liars, manipulators, untrustworthy, and things like that, then we look at answers to the issue of diversion that addresses individuals in that way, right? I think qualitative research is a great tool or a great methodology to use in this case for learning about the reasons why people are doing the things they're doing, and doing that in that systematic, like rigorous scientific methods, right? So yeah, and I think, and when we learn why people are doing what they're doing, um, we can check our understanding of how we're defining a problem or establish a new definition of the problem. And, you know, looking at it as unmet needs, or, you know, I think community needs, you know, which then demands compassionate sharing, or individual level needs, not the right dose, don't have income, then, you know, we can there are other solutions that come to the table. Yeah, there's also a question here about would you consider studying diversion by interviewing people who are not part of the Safer Supply program, so people who use drugs who are not receiving Safer Supply.
Yeah, I think I said that earlier. I think that's where we need to go next with the research. And I do think there is a recent study done by either Jeff Bardwell or Andrew. I'm misattributing to someone that does look at that. So if we can find it, it would be good to cite. But yes, absolutely. And I think,
Yeah, go ahead.
sorry to add, I think it's so important because a lot of the powerful claims that are being made right now are around who is accessing diverted meds, and it's a big question mark. We don't know with certainty, right? We have a lot of confidence from this data about what folks are telling us, but in order to have more confidence around that, we do need to speak to people who are accessing it to quantify and qualify who it is and how they're accessing and what it does for them and what their needs are.
Great. We're closing up in 4 minutes, so I'm going to stop us there. I want to say a big thank you to Michelle, Lucas, and Andrew for sharing your research, for sharing your experiences and your thoughts and perspectives on this, for being on the spot for some questions. And also a big thanks to Tanya for helping me out today. And a big thanks to all of you for taking time out of your day to be here to listen and participate, and for being patient with my technical challenges. Thank you, thank you. And I do invite you to have a look at our website if you want to learn more about the community of practice or join the community of practice. I think there's been a diversity of people who are attending this webinar, which really speaks to me about the care that we have, no matter where we are on this topic, but the care that we have about making sure that the care we provide to people who use drugs is effective, evidence-based, and yeah, thank you.
Do you mind if I talk for just a sec at the end here, Rebecca? Does that work
sorry.
for you?
Oh, yes, no, please. Yeah, there's 3 minutes left. Yeah, go ahead.
Yeah, so I mean, listen, I'm so appreciative of your guys' research. You know, and I would say in my experiences here and being around various people, conferences, often you've organized them, Rebecca, I mean, ultimately I've come to see diversion kind of through the lens of surplus versus scarcity, you know, having enough versus constantly living in a state of not enough. You know, and I can speak for myself. I've been fortunate to live a life of surplus love, safety, resources, opportunity. You know, and in many ways, I'd say I've had the privilege of being raised as a superhero. I think many in healthcare have, and I now realize how that shapes our judgment. So when we talk about diversion, I think many physicians approach it from a place of abundance. You know, how could you make this choice? Or why would you do this? Or worse, you know, why would you do this to me? But I hope in speaking about in the research or our discussions, people rethink this by imagining what it means to live in constant scarcity. You know, and sometimes January is such a powerful reminder of this. You know, I used to ask patients, how was your Christmas or whatever holiday? And it's deeply humbling when you ask that, and people, they just glance away. Like they look down in shame and they can't answer. You know, many say they've never had a Christmas, or they simply say they don't like this time of year. You know, if you sleep on the street or a shelter, excluded from society, freezing, maybe never even knew who Santa was, like this season isn't a celebration. You know, it's a terrible reminder of everything you don't have and what you've lost. And because for many, every single day is a survival. And talk about diversion and, you know, in the context of losing all these other things, encampments, safe consumption sites is, you know, it's a really terrible thing. So, you know, I made a choice, and that's the reason I'm here today. And that's to advocate, be an advocate like you guys for people who live in scarcity, you know, even when it feels uncomfortable or difficult or even scary, you know. So, and if there's any people here today who want to learn more, collaborate, or challenge their own perspectives, like you'd be welcome to reach out to any one of us to have that conversation as things get more intense. So I appreciate each one of you for being here today.
That's a great way to end our time together today. I really appreciate those words, Andrew. And yeah, it is working together where we can actually make some differences. So, yeah. Thank you all very much.
Thank you.
Take good care.
Thank you, guys.